to you, Saptarshi.
Thank you, Anibandha, for the kind words. So, though I have been in Delhi for almost last 20 years, so I am originally from Calcutta. I did my MBBS from Calcutta Medical College only. So, I think so this is just a continuation of where the last two talks were. So, we talked about the different types of diabetes, then Deep talked about childhood obesity, and we will now be looking into what we need to do as an endocrinologist for pre-conceptional checkup. So it's many. So when I got this topic, it's difficult to summarize because first of all, you need to, so there are so many endocrine disorders which have relevance, starting from thyroid, diabetes, PCOS, hyperprolactinemia, pituitary. They directly affect the fertility and the pregnancy potential, and there will be others like pre-diabetes, obesity, overweight, vitamin D deficiency, dyslipidemia, which might indirectly affect them. And in all these cases, you actually need the counseling from an endocrinologist. So if somebody has an overt disease, the endocrinologist obviously has to treat it. But even if somebody is not having an overt disease, with Deep said that he just talked on childhood obesity, and all these children, girls, when they grow up, they will carry this obesity with them. So we have a huge number of women who are planning to conceive have obesity and have multiple problems related to it. So even in some cases, though primarily the fertility issue will lie with the gynecologist, but sometimes the endocrinologists do have a role to play. And we need to be sure that we are preventing any pregnancy complications. So it has the role of an endocrinologist. It has short-term impact in terms of maternal health, but also long-term impact in terms of fetal health. And just to make it simple, I will keep it as a case discussion. So, and if the audience can pitch in if they want to have an opinion. So it's a 33-year-old lady, known case of hypothyroidism. She is planning to conceive, currently on levothyroxine 62.5 mcg. T3, T4 is normal, TSH is 2.12. So do we need to do anything? Same dose, increased dose, decreased dose? So we continue with the same dose. But what additional information we need to give in all these cases, all these women, is that the target TSH is 2.5, that is okay. But whenever they conceive, in the initial part, the maternal thyroid is responsible for maintaining fetal health and fetal growth. So the dose of thyroxine has to be, levothyroxine has to be increased by 20 to 30% immediately on conceiving. So that is a very, very important aspect. And this, many of these women are having hypothyroidism. We need to ensure that. So if you, whenever somebody is coming with you already taking medications for for hypothyroidism, you need to discuss whether there is a planning for conceiving or not. And if it's there, we need to increase the dose. We can just tell them till you meet the doctor, increase, maybe take additional 2 tablets on Saturday, Sunday. So if valid, just to make it simple, so if somebody was taking 62.5, maybe Saturday till the doctor is available, or even meeting the doctor, take 2 additional tablets on Saturday and Sunday. So we now move on to a slightly more complicated cases. That was like a basic case. So 34-year lady, 3 first trimester abortions in the past, all reports normal except TPO antibody, which is 894, clearly elevated. So do we do anything in this case? So again, any opinion? Do we replace thyroxine? We do not replace thyroxine. So there is a link of, there is a clear-cut association that in case of a elevated TPO antibody, even the person, even if the woman is euthyroid, there is an association with recurrent spontaneous abortion. But the question is, if you are giving thyroxine, are you able to prevent that? So this was a Lancet Diabetes and Endocrinology paper published in 2022. So they recommend that this was just a RCT which was done, which is like the only RCT that has been published. Otherwise, it's mostly case reports. So their finding was that even if you are supplementing thyroxine in these cases, it does not improve the pregnancy rate. The numbers were not that many. They only had around 80 patients. They were planning to get 120 patients. They could not reach the numbers because of low recruitment. So it's a gray area. But as of now, if you look into the ATA guidelines also, there is no indication to supplement thyroxine, and in this particular case, it might be proved wrong if we have subsequent studies, but current evidence is that there is, as of now, no role. So this is slightly even, this will come into the domain of endocrinology, because whenever hypothyroidism is easy, is not every time you will require an endocrinologist, but hyperthyroidism specifically in the setting of pregnancy. So there has been some changes, and we need to understand those changes. So clearly, was diagnosed with Graves' disease around 1 year back. So this was the baseline thyroid function test where the total T4 was clearly elevated, TSH clearly suppressed, was started on a dose of carbimazole 30 mg per day, and monitoring of thyroid function test was done by measuring T4 is important in this case, and all TSH normalization might take time, and it was after monitoring, when it was what we try to do is try to gradually decrease the dose of anti-thyroid medications. So, but when the dose was when a dose reduction below 20 mg was tried, she again became thyrotoxic. So now on 20 mg, her total T4 is 10.9, TSH is 0.42, almost control. So if the lady wants to conceive, so do you now continue carbimazole? Do you shift to propyl thyroxine? Do you consider radioiodine, or do you consider surgery? Again, any opinion? So that is again an evolving area. So in this case, you have actually 4 options. So you can, this is ATA hyperthyroidism guideline 2016. So definitive therapy, usually surgery is not done, but if somebody is offered a radioiodine therapy, there is a transient increase in TSH receptor antibody that passes on to the fetus, and besides, radioactivity will have its own negative effect. So conceiving should not be planned for 6 months to 1 year, and the lady will most probably require thyroxine for rest of her life if you do an ablative procedure. So that is one option. People do go for it. But you really need to be careful. Preferably document a TSH receptor antibody that it has gone down, not TPO antibody. TSH receptor antibody is different. It has functional significance. So you can get that antibody test done, and then plan, and the lady can plan pregnancy. Another option is to switch to PTU before conceiving, or another option is you can switch to PTU just after conceiving. And another, if the dose requirement is really low, so the medication requirement can actually go down in pregnancy. So in that case, you can even give a trial of stopping. So these are the advantages and disadvantages. So maybe 10-15 years back, it was a standard teaching that you shift to PTU during pregnancy and lactation in all cases. But what has been seen is that PTU has a lot of fetal hepatic necrosis possibility. 1 in 10,000 is there. And so even requiring liver transplantation or causing mortality. So most of the guidelines have really been guarded regarding long-term usage of PTU. So the idea is that it's an idiosyncratic reaction. It's not predictable. So idea is that you give PTU for as short duration as possible. Do not give propyl thyroxine for very long duration. So in somebody, if a younger female planning to conceive, regular periods, no issues, you can shift to PTU, and then after maybe once after say 12 or 14 weeks, you again shift back to methimazole or carmazole. If you are anticipating that the lady might take a longer duration, older age, PCOS, irregular periods, you can continue with methimazole or carmazole, but you have to give very specific instruction. Whenever pregnancy is detected, she has to be shifted to propyl thyroxine. So all this is because the chance of teratogenicity with propyl thyroxine is lesser than that with methimazole. So aplasia cutis, choanal atresia, esophageal atresia, omphalocele, all have been reported. In PTU, propyl thyroxine itself also causes around 2.3% of anomalies, but these are milder anomalies, so I will show you some of the examples. So this is aplasia cutis. Anyone? What is the next one? This is choanal atresia. This is preauricular sinus, and this is an omphalocele. So these all have been reported. You really need to be careful if somebody is having Graves' disease, and this is what the standard guidelines recommend for management of hyperthyroidism during pregnancy. So now we move on to a slightly different aspect. This is a 34-year-old lady having diabetes for 3 years. We increasingly keep on seeing these patients that pre-existing diabetes type 1. Now we are having more of type 2 and is on sitagliptin, metformin and glimepiride. Slight suboptimal control. So what is the target HbA1c if you are planning to have, if somebody should be conceiving? 6.5 is the target. So the lady has to come down. So what do we do in this case? Continue same treatment, shift to premixed insulin plus metformin, shift to basal bolus regimen plus metformin, or shift to basal bolus or premixed insulin annual and stop metformin? Again, any opinion? So there is actually no evidence to guide you that what should be done in this case. So if you look into the evidence, if somebody has done an RCT, so might be very small. So none of the guidelines say what ideally should be done in this case. But my practical opinion is that you make minimal changes once the lady conceives. So somebody is conceiving, you get to know at 4 to 5 weeks. 6 to 12 weeks is the most crucial time for organ formation. So you don't want glycemic fluctuation at that particular time. So I give the option of basal bolus regimen in most of my patients. Only if they refuse, I will offer an option of premixed. Metformin might be optional. Again, a gray area, lots of controversies. Somebody might be comfortable with continuing metformin, others might not be. So metformin is plus minus, but preferable if you are shifting the patient to basal bolus regimen reaching an HbA1c of 6.5, it might be the most aggressive form of therapy, but you don't have to go for any transition, because most of the ladies with type 2 diabetes, once they conceive, the fasting target is less than 95. The post-meal target is 2 hours is less than 120. With premixed insulin, it's very difficult to reach all those points. So in my practice, almost everybody who is planning to conceive or is already pregnant is on basal bolus regimen, not on a premixed insulin. Metformin is plus minus. And this is also, again, this is just general recommendation for ADA. A1C should be less than 6.5. Counseling is very, very important. Some medications actually might be very, very relevant in this case. So many of them will be on an AC inhibitor or an ARB. Many of them will be also on statin. So these are all contraindicated during pregnancy. So if somebody is on AC or ARB or statins, that has to be stopped. And the person should be shifted to safer medications. So these are the BP medications like methyl dopa, nifedipine, labetalol and clonidine, safer in pregnancy. Atenolol again should not be used if somebody is planning a pregnancy. So these are the guidelines which are there. A1C is less than 6.5%. Folic acid, actually the recommended dose is around 400 micrograms. So most of the preparations will have 5 mg. I came across an interesting article. I have not shown the slides, but excess of folic acid, so it diverts the 1-carbon metabolism towards hyperhomocystinemia. So
Folic acid 5 mg, 10 mg throughout pregnancy. Recommendation is only 400 microgram. So if you are giving excess, there is a tendency of hyperhomocystinemia that actually increases the tendency for GDM. So folic acid should be used judiciously only for the recommended period. Again, more a domain for the gynecologist. Obviously, you need to screen for complications if there is pre-existing diabetes, including renal complication, because both renal and retinal complications, they tend to worsen during pregnancy. So such screening is mandatory. If there is requirement, can be CAD evaluation can also be a part if it's required. Thyroid function testing is definitely recommended in type 1 diabetes, optional in type 2 before conceiving, and also weight reduction is very, very important. So there are some complicated situations like pituitary lesions or adrenal lesions. I will not go into that, but a very common condition is hyperprolactinemia. Prolactinoma might not be common, and most of them will be iatrogenic. So many of this, so somebody getting a domperidone tablet is like bread and butter. So every morning somebody will pop up a tablet which will have a proton pump inhibitor and a domperidone. So again, that can actually cause increase in prolactin. Levosulfide also is notorious for doing it. So these two molecules, if somebody is getting, the prolactin level might go up and even might interfere with fertility. So all these ladies, they come with MRI and all, but actually what they require is the right medicine and proper counseling. But even mild elevation in prolactin can interfere with fertility. So we need to maintain prolactin in the normal range. So we have been discussing obesity, and this is something which is important. This window for prior to conception is very, very important, because obesity is getting increasingly common and it has multiple implications, including reduced fertility and need for ART. Even if somebody is going for ART, the risk of success actually goes down. So something very, very important. And there are meta-analysis that with increasing weight, with increasing BMI, the chance of becoming pregnant and live birth, they both actually goes down. And if you actually intervene by even lifestyle intervention, so the risk settles down, so that there is a higher chance of becoming pregnant and conceiving. And we are all thinking about all talking about the importance of obesity. So there is obviously the chance of development of GDM if somebody is obese. There is a chance of development of preeclampsia or hypertension. But again, so there is actually carryover effect into the fetus also. So obesity, the metabolic, there are early epigenetic changes, metabolic programming of the fetus that can actually translate to higher metabolic risk in the fetus and future risk of cardiovascular disease and diabetes. So this is a window which has very, very long-term implication. So weight loss and in Indian context, even maintaining the right balance of carbohydrate, protein and fat, and also the micronutrients, they all become important. So finally, to summarize, so it's a very broad area, and the endocrinologist might have multiple roles, but obviously treatment of pre-existing disease is important. If it's not there, if somebody is obese, so that also requires understanding, and that can have both implications for pregnancy, for the fetus, and also for long-term metabolic and cardiovascular outcome of the progeny. And very, very important, we need to be careful about choice of medications. Many of the problems are iatrogenic, and you need to avoid medications which have teratogenicity or can interfere with fertility potential. And if somebody is having any of these complications, they are usually very serious just prior to conceiving and during pregnancy. So we have a very, very low follow-up rate for GDM. So we should all be doing an OGTT at 6 weeks in women with GDM, but it's hardly done. So it's very important to have long-term follow-up in all these women. Thank you for your patience.